The VA team discusses updates to the electronic health record and changes could be in our future for hypertension compensation.
One. Two, we've talked about this in the course of the last several months to include in the course of the debate as we've asked for additional funding for VHA. We provided 131 million healthcare appointments last year, also a record. And we did that at a time when veteran satisfaction and veteran trust reached record highs at about 91.8% veteran trust for VA outpatient services. So I'm really proud of the workforce on that. Third, we've also grown the workforce in the last several years. And so not only, we've been able to grow that through a variety of means, most profoundly, the mission at VA. This is the best mission in the federal government. Secondly, we've been able to make investments using new VA, new tools for pay enhancements, which were a long time in coming at VA, where we are now even more competitive with other, for example, healthcare providers.
Secretary McDonough, over a year ago, you talked about doing a review of the hypertension claims. There was like 83% were zero under the PACT Act. Can we get an update? It's great to have you here under Secretary Jacobs. That'd be great.
If we can just go straight to Josh.
That'd be great.
Because he actually knows something.
Okay.
Yeah. Well, thanks very much for raising that question and concern. The issue that you're raising is that under the PACT Act, we now cover hypertension as a presumptive for Vietnam veterans. And we've seen a surge of those claims. One of the concerns that we've heard as we're working to deliver those earned benefits is that some veterans have been receiving a 0% service connection. That means that they are service connected for hypertension, but they don't receive compensation for it, albeit there are ways in which they can if it's combined. It does open the door for additional healthcare eligibility and enhanced services on the healthcare side. But the net impact among some veterans is a belief that they need to go off their medication to receive a higher disability rating. And we are actively communicating to veterans with hypertension to not do that. The question that you asked, though, is what are we doing here? And so we've developed an IPT to try to make it easier we have developed an IPT with our cardiologist partners in the health system to identify opportunities to make some improvements there. There's active work in process. It is in the rulemaking process, so I'm somewhat limited in terms of what I can say, but those activities are underway.
Okay, so it's in the rulemaking process, but a preliminary proposed rule hasn't been published yet, right? Okay. Is there any movement afoot? VA has a pretty high threshold for what is high blood pressure that's actually very different than what is medically accepted. So is that being considered in that
rule? That's actively part of the effort that is underway, is to align it with the current medical understanding of blood pressure readings.
Any timeline on that?
I would have to get back to you on that.
Yeah. Okay.
I want to go back on the hypertension point. That, I think I don't know if it's the AMA or whoever manages the medical evidence on this has changed what's elevated, what's high blood pressure, just in the last year or so. So we are making sure that we catch up with that.
Hello, thanks for doing this. I had a question about the EHR program. I know we've talked about it throughout the year, but thinking about as we get to the end of the year and eventually end of the administration, how are you working with the presidential transition team to prepare and eventually hand off the program?
Yeah, so we don't have any new news about the transition team. So when the team gets here, we'll make sure that we make that public, and this will be among the things that we're going to want to talk to that team about. So we don't have any updates on how we're talking to the next team about the EHRM.
Well, let me ask, how are you preparing for it, going into next year then?
Well, we've been working in the context of the reset to make sure that we're in a position to learn everything that we possibly can about the performance of the system and the upgrades of the system. We're making sure that, since the go live in March 2024 in Chicago, that we've been pleased with the progress of the EHR system at the Lovell joint facility that we run with the United States Navy. It's obviously still too early to declare final or unequivocal success. There have been some promising results. Importantly, I think across each of the EHR systems, we've seen increased veteran trust since the EHR go lives. We've seen decreased wait times. We've seen dramatically decreasing disruptions in patient care since January 2024. We're seeing decreasing numbers of interruptions for clinicians, therefore minimizing the slowdowns for veterans. We're seeing an increased clinician and staff satisfaction, but there's still, I just want to underscore, as I will with each of these generally, but let me specifically say here, there's still room to improve there, dramatic room to improve, but we're seeing increased clinician and staff satisfaction. And we do feel like the EHR launch in Chicago was a success. This all adds up to the thing that we care about most, which is better care for vets that we serve and a better experience for the clinicians who serve them. So we'll be sharing all of those findings with the transition team. But remember that there's a relatively small number of political appointees here at VA. So the overwhelming majority of VA professionals who work on EHRM will be working on EHRM on January 21st, just as they were on January 19th. So that team stays, and we've benefited greatly from our opportunity to work with them. And I say our by that I mean those of us who are political appointees. So that work, the reset work continues. We feel good about it. There's still a lot of work to be done. We'll make sure that the transition team has a really good understanding of that. But in all cases, also the team that works, this is a team that's going to be here, is here now, and will be here deep into the next administration.
Thank you.
It seems that the way hypertension is rated for compensation does not align with some of the new documentation from the medical field. Most important thing that I heard on this: number one, you have high blood pressure. Number two, you served in Vietnam. Number three, you don't have a relationship with the VA. Go to the VA and submit a claim. The door is open. As far as any of the changes are concerned, we have to keep an eye out on the next couple of years as they figure out the right compensation situation. What worries me is that veterans are not taking their medicine just to get their numbers a particular way for compensation. They need to fix that. Veterans should not feel they need to stop taking their medicine for any reason. The political transition for EHR, in case I had to look that up, it's the electronic health record. Supposedly it's doing great things since they went live. It should have no impact right away. But as you know, different leaders come in, they might want to make some changes after they get their feet wet. Can't say that's a big surprise because we did that every time we PCSed as leaders. You got into a new spot, you wanted to see how the team worked, see how they got everything done. Is it in line with the Marine Corps for myself, but for all of you, your services regulations? If it is, did it work? Or were you going to get in there, get your hands dirty, and change it to the way that you want it to be? But none of that stuff could be done right away. Well, shouldn't be done right away. 4 down, 5 videos to go to break down the VA press conference from December. Like and subscribe to be able to see the rest of the topics as soon as they are released.